Today my lecture will be devoted for breast abscess and breast masses. Mastitis is inflammation of the breast, usually associated with breastfeeding. Symptoms typically include local pain and redness. There is often an associated fever and general soreness. Onset is typically fairly rapid and usually occurs within the first few months of delivery. Complication can include abscess formation. Risk factors include poor latch, cracked nipples, use of a breast pump, and weaning. The bacteria most commonly involved are Staphylococcus and Streptococcus. Diagnosis is typically based on symptoms. Ultrasound may be useful for detecting a potential abscess. Prevention is by frequently and properly breastfeeding. When infection is present, antibiotics such as cephalexin may be recommended. Breastfeeding should typically be continued as emptying the breast is important for healing. Tentative evidence supports benefits from probiotics. About 10% breastfeeding women are affected. Signs and symptoms. Lactation mastitis usually affects only one breast and the symptoms can develop quickly. The signs and symptoms usually appear suddenly and they include breast tenderness or warmth to the touch, general malaise or feeling ill, swelling of the breast, pain or a burning sensation continuously or while breastfeeding, skin redness, often in a wedge-shaped pattern, fever. The affected breast can then start to appear lumpy and red. Some women may also experience flu-like symptoms such as shivering and chills, feeling anxious or stressed, fatigue. Contact should be made with a health care provider with a special breastfeeding competence as soon as the patient recognizes the combination of signs and symptoms. Most of the women first experience the flu-like symptoms and just after they may notice a sore red area on the breast. Also, women should seek medical care if they notice any abnormal discharge from the nipple, if breast pain is making it difficult to function each day, or they have prolonged unexplained breast pain. Breast abscess. A breast abscess is a collection of pus that develops into the breast with differing causes. During lactation, breast abscess develops only rarely. Most sources cite about 0.4–0.5% of breastfeeding women. Known risk factor: age, over 30, premenopausal and late delivery. No correlation was found with smoking status. However, this may be in part because much fewer smoking women choose to breastfeed. Antibiotics were not shown effective in prevention or lactation abscess but are useful to treat a secondary infection. Causes. Since 1980s, mastitis has often been divided into non-infectious and infectious subgroups. However, recent research suggests that it may not be feasible to make division in this way. It has been shown that the amounts of the potentially pathogenic bacteria in breast milk are not correlated to the severity of symptoms. Moreover, although only 15% of women with mastitis studied were given antibiotics, all recovered and few had recurring symptoms. Many healthy breastfeeding women wishing to donate breast milk have potentially pathogenic bacteria in their milk but have no symptoms of mastitis. Risk factors. Mastitis typically develops when the milk is not properly removed from the breast. Milk stasis can lead to the milk ducts in the breast becoming blocked as the breast milk is not being properly and regularly expressed. It has also been suggested that blocked milk ducts can occur as a result of pressure on the breast, such as light-fitting clutching or an over-restrictive bra, although there is sparse evidence for this supposition. Mastitis may occur when the baby is not appropriately attached to the breast while feeding, when the baby has infrequent feeds, or has problems sucking the milk out of the breast. The presence of cracks or sores on the nipples increases the likelihood of infection. Tight clothing or tight-fitting bras may also cause problems as they compress the breast. There is possibility that infants carrying infectious pathogens in their noses can infect their mother. The clinical significance of these findings is still unknown. Mastitis as well as breast abscess can also be caused by direct trauma to the breast. Such injury can occur, for example, during sports activities or due to seat belt injury. Mastitis can also develop due to contamination of the breast implant or any other foreign body, for example, after nipple piercing. In such cases, the removal of the foreign body is indicated. Women who are breastfeeding are at risk for developing mastitis, especially if they have sore or cracked nipple or have had mastitis before while breastfeeding another baby. Also, the chance of getting mastitis increases in women use only one position to breastfeed or wear a tight-fitting bra, which may restrict milk flow. Difficulties in getting a nursing infant to latch on to the breast can also increase the risk for mastitis. Infection. Some women will require antibiotics treatment for infection, which is usually caused by bacteria from the skin of the or baby mouth that entering the milk duct through the skin lesions of the nipple or through the opening of the nipple. Infection is usually caused by Staphylococcus aureus. Infectious pathogens commonly associated with mastitis are Staphylococcus aureus, Streptococcus, and gram-negative bacilli such as Escherichia coli, Salmonella, Mycobacteria, and fungi such as Candida and Cryptococcus have been identified in rare instances. Recent research suggests that infection pathogens play a much smaller role in the pathogenesis than one commonly assumed only a few years ago. Most detected pathogens are very common species that the natural part of the breast fauna and simple detection of their presence is not sufficient to prove a causative role. Pregnancy-related puerperal mastitis is the inflammation of the breast in connection with pregnancy, breastfeeding, or wearing. Since one of the most prominent symptoms is tension and engorgement of the breast, It's thought to be caused by blocked milk ducts or milk excess. It is relatively common. Estimates range depending on methodology between 5 and 33%. However, only about 0.4–0.5% of breastfeeding mothers develop an abscess. Some predisposing factors are known, but their predictive value is minimal. It appears that proper breastfeeding technique, frequent breastfeeding, and avoidance of stress are the most important factors that can be influenced. Diagnosis. The diagnosis of mastitis and breast abscesses can usually be made based on the physical examination. Actually, the doctor will also take into account the signs and symptoms of the condition. However, if the doctor is not sure whether the mass is an abscess or tumor, a breast ultrasound may be performed. The ultrasound provides a clear image of the breast tissue and may be helpful in distinguishing between simple mastitis and abscess, or in diagnosing an abscess deep in the breast. The test consists of placing an ultrasound probe over the breast. In cases of infectious mastitis, cultures may be needed in order to determine what type of organism is causing the infections. Cultures are helpful in deciding the specific type of antibiotics that will be used in curing the disease. The cultures may be taken either from the breast milk or of the material aspirated from an abscess. Mammogram or breast biopsy are normally performed on women who don't respond to treatment or on non-breastfeeding women. This type of test is sometimes ordered to exclude the possibility of a rare type of breast cancer which causes symptoms similar to those of mastitis. Treatment. In lactation mastitis, frequent emptying on both breasts by breastfeeding is essential. Also essential is adequate fluid supply for the mother and baby. For breastfeeding women with light mastitis, massage and application of heat prior to feeding can help, as this may aid in blocking the duct. However, in more severe cases of mastitis, heat or massage could make the symptoms worse, and cold compresses are better suited to contain the inflammation. Non-puerperal mastitis is treated by medication and possibility aspiration or drainage. In idiopathic granulomatous mastitis, successful treatment includes invasive surgical procedure or less invasive treatment with steroid medicamentation. In lactational mastitis, antibiotics are not needed in the overwhelming majority of cases and should be used only for bacterial infection. For people with non-severe infections, diocloxacillin or cefalexin and others antibiotics by fifth generation are recommended. For people with severe infection, vancomycin is recommended. Breast abscess. An abscess or suspected abscess in the breast may be treated by ultrasound-guided fine needle aspiration, percutaneous aspiration, or by surgical IND, means incision and drainage. Each of these approaches is performed under antibiotic coverage. In case of puerperal breast abscess, breastfeeding from the affected breast should be continued where possible. For small breast abscesses, ultrasound-guided fine needle aspiration, such as to completely drain the abscesses, is widely recognized as a preferred initial management. One recommended treatment includes antibiotics, ultrasound evaluation, and if fluid is present, ultrasound-guided fine needle aspiration of the abscesses with an 18-gauge needle under saline lavage until clear. The exudate is then sent for microbiological analysis for identification of the pathogen and determination of its antibiotic sensitivity profile, which may in turn give an indication for changing the antibiotics. At follow-up, a mammography is performed if the condition has resolved. Otherwise, the ultrasound-guided fine needle aspiration with lavage and microbiologic analysis is repeated. If 3 to 5 aspirations still don't resolve the condition, percutaneous drainage is combination with placement of an indwelling catheter is indicated, and only if several attempts at ultrasound-guided drainage failed, surgical resection of the inflamed lactiferous ducts, preferably performed after the acute episode is over. It's not, however, that even the excision of the affected ducts does not necessarily prevent recurrence. Although there are a number of recommendations regarding the treatment of breast abscess, a 2015 review found not enough evidence regarding if needle aspiration is comparable to incision and drainage, or if antibiotics should generally be given to women undergoing incision and drainage. Breast masses. Carcinoma of the female breast. Common signs and symptoms. The most common signs and symptoms of breast disease is a palpable mass. This is usually found by the patient and may lead to the diagnosis of either benign or malignant disease. A palpable mass may be smooth and rubbery, fibroadenoma, dense cyst, or firm and irregular carcinoma. While many patients complain of breast pain, this is not commonly associated with the serious diseases and usually is due to underlying fibrocystic changes in a premenopausal woman. However, some patients who complain of pain are found to have a malignancy. Most commonly, patients have a diffuse nodularity associated with pain leading to the clinical diagnosis of fibrocystic disease. Benign and malignant breast disease may present as nipple discharge or even erosion or an eczema-like rash of the nipple. Most nipple discharge is associated with benign duct, ectasia, or cyst. A bloody discharge can be a sign of malignancy, but is usually a sign of a benign intraductal papilloma. Nipple erosion or even of eczema like rash can be related to an underlying malignancy, as in Paget disease. More diffuse skin changes can also be seen into benign and malignant conditions. Erythema and edema may signify underlying mastitis or advanced or inflammatory carcinoma. Breast tenderness is associated most commonly with fibrocystic disease, but when accompanied by erythema and edema, it signifies mastitis. Local skin dumping indentation or nipple retraction may be a sign of benign fibrocystic disease or a part mastitis, but may signify an underlying malignancy. Rarely, a malignancy may present with a palpable adenomopathy and no abnormality within the breast itself. A malignancy may be very obvious, presenting with a mass, adenopathy, and skin involvement, or may be a subtle thickening in a portion of a breast with no other identifiable abnormality. While the overwhelming majority of patients with complaints related to their breast will have benign conditions, most breast symptoms and signs may be due to an associated or underlying malignancy and warrant workup and follow-up care. Diagnostic tests. The most reliable diagnostic test for breast cancer is open excisional biopsy. When the sample is properly taken by the surgeon and examined by the pathologist, such a test should give no false negative and no false positive results. Large needle core needle biopsy is an accepted diagnostic technique in which a core of tissue is removed with a large cutting needle. As in the case of any nipple biopsy, the main problem is sampling error due to improper positioning of the needle, giving rise to a false negative test result. Fine needle aspiration cytology is a useful technique whereby cells from a breast tumor are aspirated with a small needle and examined by the pathologist. These techniques can be performed easily with no morbidity and is much less expensive than excisional or open biopsy. The main disadvantage are that it requires a pathologist skilled in the cytologic diagnosis of breast cancer and that it is subject to sampling problems, particularly because depletions may be missed. The incidence of false positive diagnosis is extremely low, perhaps 1–2%. The rate of false negative diagnosis with fine needle aspiration biopsy is a high as a 10% in some series. Most experienced clinicians would not leave a dominant mass in the breast even when fine needle aspiration cytology is negative unless the clinical diagnosis, breast imaging, and cytologic studies were all in agreement. Ultrasonography is performed chiefly to differentiate cystic from the solid lesions, and it's not diagnostic of malignancy. Ultrasonography may show an irregular mass within a cyst in the rare case of an intracystic carcinoma. If a tumor is palpable and clinically feels like a cyst, an 80-gauge needle can be used to aspirate the fluid and make the diagnosis of cyst. If a cyst is aspirated and the fluid is non-bloody, it does not have to be examined cytologically. If the masses does not recur, no further diagnostic test is necessary. Non-palpable mammographic densities that appear benign should be investigated with ultrasound to determine whether the lesion is cystic or solid. When a suspicious abnormality is identified by mammography alone and cannot be palpated by the clinician, the patient should undergo mammographic localization biopsy. This is performed by obtained a mammogram in two perpendicular views and placing a needle or hook wire near the abnormality so that the surgeon can use a metal needle or wire as a guide during operation to locate the lesion. After mammography confirms the position of the needle in relation to the lesion, an incision is made and the subcutaneous tissue is dissected until the needle is identified. Using the films as a guide, the abnormality can then be localized and excised. Incidence and risk factors. The breast is the most common site of cancer in women. The cancer of the breast is second only to lung cancer as a cause of death from cancer among the women. The probability of developing breast cancer increases throughout life. The mean and the median age of women with breast cancer is between 60 and 61 years old. Women whose mother or sister had breast cancer are more likely to develop the disease than others. Risk is increased in patients whose mother or sister breast cancer occurred before menopause or was bilateral, and in those with a family history of breast cancer in the two or more first-degree relatives. However, there is no history of breast cancer among female relatives in over 90% of breast cancer patients. A woman who has had cancer in one breast is at increased risk of developing cancer in the other breast. Women with cancer of the uterine corpus have a breast cancer risk significantly higher than that of the general population, and women with a breast cancer have a comparably increased endometrial cancer risk. Oral contraceptives don't appear to increase the risk of breast cancer. There is some evidence that administration of estrogens to postmenopausal women may result in a slightly increased risk of breast cancer. But studies suggest that women with a family history of breast cancer who take postmenopausal estrogens or those who take estradiol or unconjugated estrogens do slightly that increase their risk of breast cancer. Women who are at greater than normal risk of developing breast cancer should be identified by their physicians, taught the techniques of breast self-examinations, and followed carefully. Screening program involving periodic physical examination and mammography of asymptomatic high-risk women increase the detection rate of breast cancer and improve the survival rate by as much as 30%. Unfortunately, most women who develop breast cancer don't have significant identifiable risk factors, and analysis of epidemiologic data has failed to identify women who are not at significant risk and would not benefit from screening. Early detection of breast cancer. Screening programs. A number of mass screening programs consisting of physical and mammographic examination of the breast of asymptomatic women have been conducted. Such programs frequently identify more than 6 cancers per 1,000 women. About 80% of these women have negative axillary lymph nodes at the time of surgery, whereas only 45% of patients found in the course of usual medical practice have uninvolved axillary nodes. Detecting breast cancer before it has spread to the axillary nodes greatly increase the chance of survival, and about 85% of such women will survive at least 5 years. But physical examination and mammography are necessary for maximum yield in screening programs, since about 35–50% of early breast cancer can be discovered only by mammography, and another 40% can be detected only by palpation. A woman over age 40 should have early yearly breast examination. The sensitivity of mammography varies from approximately 60% to 90%. This sensitivity depends on several factors, including patient age, breast density, tumor size, location, and mammographic appearance. In young women with dense breasts, mammography is less sensitive than in the older woman with fatty breasts. In home mammography can detect nearly 90% of malignancies. Smaller tumors, particularly those without calcifications, are more difficult to detect, especially in dense breasts. The lack of sensitivity in young women is leading to questions concerning the value of mammography for screening in women 40–50 years of age. A baseline mammogram should be performed on all women between age 35 and 40 years. Women aged 40–49 years should have a mammogram every 1–2 years. Annual mammograms are indicated for women aged 50 years and or older. Ductography is useful to evaluate the cause of nipple discharges. In this study, the radiologist injects contrast medium into the discharging duct and obtains a mammogram. The injected duct may contain a filling defect, most commonly an intraductal papilloma, or may have a dilated or cystic appearance. Patient with duct ectasia or fibrocystic disease. Malignancy may appear as an abrupt obstruction or filling defect. All women over age 20 years should be advised to examine their breasts monthly. Premenopausal women should perform the examination 7–8 days after the menstrual period. The breast should be inspected initially while standing before a mirror with the bands at the sides overhead and pressed firmly on the hips that contrast the pectoralis muscles. Masses, asymmetry of breast, and slight damping of the skin may become apparent as a result of this maneuvers. Next, in the supine position, each breast should be carefully palpated with the fingers of the opposite hand. Physicians should instruct women in the technique of self-examination and advise them to report at once for medical evaluation if a mass or other abnormality is noted. Some women discover small breast lumps more readily when their skin is moist while bathing or showering. Most women don't practice self-examination, and its value is controversial. Clearly, however, it's not harmful and may be beneficial. Mammography is the most useful technique for the detection of early breast cancer. Mammography is the only reliable means of detecting breast cancer before a mass can be palpated in the breast. Slowly growing breast cancers can be identified by mammography at least 2 years before reaching a size detectable by palpation. Calcification are the most easily recognized mammographic abnormality. The most common mammographic abnormalities associated with carcinoma of the breast and are clustered polymorphic microcalcification. Indications for mammography are as follows. First, to evaluate each breast when a diagnosis of potentially curable breast cancer has been made, and at yearly intervals thereafter. Second, to evaluate a questionable or ill-defined breast mass or other suspicious change in the breast. Third, to search for an occult breast cancer in a woman with metastatic disease in axillary nodes or elsewhere from an unknown primary. Fourth, to screen women prior to cosmetic operations or prior to biopsy of a mass, to examine for an unsuspected cancer. Fifth, to screen at regular intervals a selected group of women who are at high risk for developing breast cancer. Sixth, to follow those women with breast cancer who have been treated with breast conserving surgery and radiations. Patients with a dominant or suspicious mass must undergo biopsy despite mammographic findings. The mammogram should be obtained prior to biopsy so that other suspicious areas can be noted and the contralateral breast can be checked. Mammography is never a substitute for biopsy because it may not reveal clinical cancer in a very dense breast, as may be seen in young women with mammary dysplasia, and may not reveal medullary type cancer. Clinical findings and diagnosis. The patient with breast cancer usually presents with a lump in the breast When the history is taken, special note should be made of breast cancer risk factors, the temporal relationship of mass to menstrual cycle, and previous breast problems. Clinical evaluation should include assessment of the local lesion and a search for evidence of metastasis in radial nodes or distant sites. After the diagnosis of breast cancer has been confirmed by biopsy, additional studies are often needed to complete the search for distant metastasis or an acute primary in the other breast. Then, before any decision is made about treatment, all the available clinical data are used to determine the extent or stage of the patient disease. Symptoms. The presenting complaints in about 70% of patients with breast cancer is a lump, usually painless, in the breast. About 90% of breast masses are discovered by the patient herself. Less frequent symptoms are breast pain, nipple discharges, erosion, retraction, enlargement, or itching of the nipple, and redness, generalized hardness, enlargement, or shrinking of the breast. Rarely, an axillary mass or swelling of the arm may be the first symptom. Back or bone pain, jaundice, or weight loss may be the result of systemic metastasis, but these symptoms are rarely seen or initial presentation. The relative frequency of carcinoma in various anatomic sites in the breasts. Inspection of the breast is the first step in physical examination and should be carried out with the patient sitting, arms at sides and then overhead. Abnormal variations in breast size and contour, minimal nipple retraction, and slight edema, redness or retraction of the skin can be identified. Asymmetry of the breast and retraction or dumpling of the skin can often be accentuated by having the patient raise her arms overhead or press her hand on her hips in order to contract the pectoralis muscles. Axillary and supraclavicular areas should be thoroughly palpated for enlarged nodes with the patient sitting. Palpation of the breast for masses or other changes should be performed with the patient both seated and supine with the arm abducted. Some authorities recommend palpation with a rotary motion of the examiner's fingers as well as horizontal stripping motion. Breast cancer usually consists of a non-tender, firm or hard lump with poorly delineated margins caused by local infiltration. Slight skin or nipple retraction is an important sign. Minimal asymmetry of the breast may be noted. Very small, approximately 1–2 millimeters, erosion of the nipple epithelium may be the only manifestation of paged carcinoma. Watery, serous, or bloody discharge from the nipple is an occasional early sign, but is more often associated with benign disease. A lesion smaller than 1 centimeter in diameter may be difficult or impossible for the examiner to feel and yet may be discovered by the patient. She should always be asked to demonstrate the location of the mass. If the physician fails to confirm the patient's suspicions, the examination should be repeated in 1 month, preferably 1-2 weeks after the onset of menses. The following are characteristic of advanced carcinoma: edema, redness, nodularity or ulceration of the skin, the presence of a large primary tumor, fixation to the chest wall, enlargement, shrinkage, or retraction of the breast, marked axillary lymphadenopathy, supraclavicular lymphadenopathy, edema of the ipsilateral arm, and distant metastasis. Metastases tend to involve regional lymph nodes, which may be clinically palpable. With regard to the axilla, 1 or 2 movable, non-tender, non-particularly firm lymph nodes 5 mm or less in diameter are frequently present and are generally of no significance. Firm or hard nodes larger than 5 mm in diameters usually contain metastasis. Axillary nodes that are matted or fixed to skin or deep structures indicate advanced disease. Histologic studies show that microscopic metastases are present in about 30% of patients with clinically negative nodes. Laboratory findings: a consistently elevated sedimentation rate may be the result of disseminated cancer. Liver or bone metastasis may be associated with elevation of serum alkaline phosphatase. Hypercalcemia is an occasional important finding in advanced cancer of the breast. Imaging for metastasis: chest radiographs may show pulmonary metastasis. CT scanning of the liver and brain is of value only when metastases are suspected in these areas. Biopsy: the diagnosis of breast cancer depends ultimately upon examination of tissue removed by biopsy. Treatment should never be undertaken without any unequal histologic diagnosis of cancer. The safest found on physical examination and in the absence of a mass of suspicious lesions demonstrated by mammography. Dominant masses or suspicious, non-palpable. The fallibility of clinical judgment and the necessary for biopsy. A breast mass should not be followed without histologic diagnosis, except perhaps in the premenopausal woman with a non-suspicious mass presumed to be fibrocystic disease. A lesion such as this could be observed through 1 or 2 menstrual cycles. However, if the mass does not completely resolve during this time, it must be biopsied. The simplest method is needle biopsy either by aspiration of tumor cells, fine needle aspiration cytology, or by obtaining a small core of tissue with an Wien Silverman or other special needle. A non-diagnostic needle biopsy or fine needle aspiration should be followed by open biopsy. Open biopsy under local anesthesia as a separate procedure prior to deciding upon definitive treatment is the most reliable means of diagnosis. Needle biopsy or aspiration, when positive for malignancy, offers a more rapid approach with less morbidity, but when non-diagnostic, it must be followed by excisional biopsy. Special clinic forms of breast cancer. Paget carcinoma. The basic lesion is usually an infiltrating ductal carcinoma, usually well differentiated. The nipple epithelium is infiltrated, but gross nipple changes are often minimal, and a tumor mass may not be palpable. The first symptom is often itching or burning of the nipple with superficial erosion or ulceration. The diagnosis is established by a biopsy of the erosion. Paget carcinoma is not common, about 1% of all breast cancers, but it's important because it's appears unaccouchous. It's frequently diagnosed and treated as dermatitis or bacterial infection, leading to an unfortunate delay in detection. When the lesion consists of nipple changes only, the incidence of axillary metastasis is about 5%, and the prognosis is excellent. When a breast tumor is also present, the incidence of axillary metastasis rises with an associated marked decrease in prospect for cure by surgical or other treatment. Non-invasive cancer. Non-invasive cancer can occur within the ducts, the ductal carcinoma in situ, or lobular carcinoma in situ. While ductal carcinoma in situ behaves as an early malignancy, lobular carcinoma in situ would perhaps be better called lobular neoplasia. Ductal carcinoma in situ tends to be unilateral and most likely progress to invasive cancer. Approximately 40–60% of women who have the ductal carcinoma in situ treated with biopsy alone will develop invasive cancer within the same breast. Lobular carcinoma in situ, however, appears to be more of a risk factor, calling attention to the probability of developing invasive cancer in either breast. Approximately 20% of women with lobular carcinoma in situ will develop invasive cancer, usually ductal. This invasive cancer occurs with equal frequency in either breast. The treatment of intraductal lesions is controversial. Ductal carcinoma can be treated with total mastectomy or breast conservation with wide excision with or without radiation therapy. Lobular carcinoma in situ is probably best managed with careful observation. However, patients who are unwilling to accept the increased risk of breast cancer may be offered bilateral total mastectomy. Axillary metastases are rare. Curative treatment. Treatment may be curative or palliative. Curative treatment is advised for clinical stage 1 and stage 2 disease. Patients with locally advanced stage 3 tumors may be cured with multimodality therapy, but in most cases, palliation is all that can be expected. Palliative treatment is appropriate for all patients with stage 4 disease and for previously treated patients who develop distant metastasis or who have unresectable local cancer. Modified radical mastectomy, total mastectomy, plus axillary lymph node dissection has been the standard therapy for most patients with breast cancer. This operation removes the entire breast, overlying skin, nipple, and areolar complex, as well as the underlying pectoralis fasciae with the axillary lymph nodes in continuity. It offers the same overall cerebral and local control rates as does lumpectomy with axillary dissection and postoperative radiation therapy. The major advantage of modified radical mastectomy is that radiation therapy is usually not necessary. The disadvantage, of course, is the physiologic trauma associated with breast loss. Radical mastectomy, which removes the underlying pectoralis muscle, should be performed rarely, if at all. Axillary node dissection is not indicated for non-infiltrating cancer because nodal metastases are rarely present. Chemotherapy or hormonal therapy is advocated for most patients with curable breast cancer. The objective of adjuvant therapy is to eliminate the occult metastases responsible for late recurrence while they are microscopic and theoretically most vulnerable to anti-cancer agents. Palliative treatment. Palliative radiotherapy may be advised for locally advanced cancer with distant metastasis in order to control ulceration, pain, and other manifestations in the breast and regional nodes, irradiation of the breast and chest wall and the axillary, internal mammary, and supraclavicular nodes should be undertaken in an attempt to cure locally advanced and inoperable lesions when there is no evidence of distant metastasis. A small number of patients in this group are cured in spite of extensive breast and regional node involvement. Adjuvant chemotherapy should be considered for such patients. Palliative irradiation is of value also in the treatment of certain bone or soft tissue metastases to control pain or avoid fracture. Radiotherapy is especially useful in the treatment of isolated bony metastasis and chest wall recurrence. Chemotherapy. Cytotoxic drugs should be considered for the treatment of metastatic breast cancer if visceral metastases are present, especially brain or lymphangitic pulmonary. Second, if hormonal treatment is unsuccessful or the disease has progressed after an initial response to hormonal manipulation. Combination chemotherapy using multiple agents has proved to be more effective, with objectively observed favorable response achieved in 60–80% of patients with stage 4 disease. Various combinations of drugs have been used, and clinical trials are continuing in an effort to improve results and reduce undesirable side effects. Mammary dysplasia, general considerations. This disorder, also known as fibrocystic disease or chronic cystic mastitis, is the most frequent lesion of the breast. It's common in women 30–50 years of age, but rare in post-menopausal women. This suggests that it is related to ovarian activity. Estrogen hormone is considered a causative factor. The term mammary dysplasia or fibrocystic disease is impressive and encompasses a wide variety of pathologic entities. These lesions are always associated with benign changes in the breast epithelium, some of which are found so commonly in normal breast that they are probably variants of normal breast histology, but have unfortunately been termed a disease. The microscopic findings of fibrocystic disease include cyst, gross and microscopic papillomatosis, adenosis, fibrosis, and ductal epithelial hyperplasia. Also, mammary dysplasia has generally been considered to increase the risk of subsequent breast cancer. Only the variants in which proliferation of epithelial components is demonstrated to represent through risk factors. Mammary dysplasia may produce as a asymptomatic lump in the breast that is discovered by accident, but pain or tenderness often calls attention to the mass. They may be discharged from the nipple. In many cases, discomfort occurs or is increased during the premenstrual phase of the cycle, at which time the cysts tend to enlarge. Fluctuation in size and rapid appearance or disappearance of a breast tumor are common in cystic disease. Multiple or bilateral masses are common, and many patients will give a history of a transient lump in the breast or cyclic breast pain. Because mammary dysplasia is frequently indistinguishable from carcinoma, on the basis of clinical findings, suspicious lesions should be biopsied. Fine needle aspiration cytology may be used, but if a suspicious mass that's non-malignant on cytologic examination does not resolve over several months, it must be excised. Surgery should be conservative since the primary objective is to exclude cancer. Simple mastectomy or extensive removal of breast tissue is rarely if ever indicated for mammary dysplasia. When the diagnosis of mammary dysplasia has been established by previous biopsy or is practically certain because the history is classic aspiration of a discrete mass suggestive of a cyst is indicated, the patient is re-examined and at intervals thereafter. If no fluid is obtained or if fluid is bloody, if a mass persists after aspiration, or if at any time during following up a persistent lump is noted, biopsy examination should be performed. Breast pain associated with generalized mammary dysplasia is best treated by avoiding trauma and by wearing night and day a brassiere that gives good support and protection. Hormone therapy is not advisable because it does not cure the condition and has undesirable side effect. Fibroadenoma of the breast. This common benign neoplasm occurs most frequently in young women, usually within 20 years after puberty. It is somewhat more frequent and tends to occur at an earlier age in black than in white women. Multiple tumors in one or both breasts are found in 10–15% of patients. The typical fibroadenoma is a round, firm, discrete, relatively movable, non-tender mass, 1–5 cm in diameter. The tumor is usually discovered accidentally. Clinical diagnosis in young patients is generally not difficult. In women over 30 years, cystic disease of the breast and carcinoma of the breast must be considered. Cysts can be identified by aspiration. Fibroadenoma does not normally occur after the menopause, but post-menopausal women may occasionally develop fibroadenoma after administration of estrogenic hormone. Treatment is by excision under local anesthesia as an outpatient procedure with pathologic examination of the specimen. Thank you very much for your attention.